I want to first thank UMass for inviting me to give another talk on the role of enteroviruses in this illness. I thought this time I put more emphasis on the clinical laboratory diagnosis and then offer some preliminary data on treatment. I'd like to present a case first. As you can see on the screen, in July of 2003, a 49-year-old white female developed a severe flu-like illness while living in Incline Village, was next to Lake Tahoe, Nevada. She's been there for 14 months. She has not traveled outside the area, so the disease was definitely acquired there. She developed low-grade fever, chills, myalgia, severe sore throat, and throat swelling, followed by severe debilitating neck pain, headaches, without sinus congestion, cough, chest pain, headache, without diarrhea, headache she has. She went to the emergency room at 1 week of illness. She has severe neck tenderness, and regular blood counts and thyroid function tests and erythrocyte sedimentation rates were all normal. Chest X-ray scan of the brain, CT scan of the brain, lumbar puncture were unremarkable. She was thought to have either a lupus or a virus infection, and the emergency room physician gave her a tapering course of glucocorticoids and then Celebrex, which did help the neck pain to some extent. The acute illness lasted about several weeks, but the fatigue and the neck pain never resolved. Subsequently, she developed relapsing symptoms of CFS, you can see there. She also had nausea and indigestion for the first time in her life. She was given Metrodose pack 3 more times by either the emergency room or the local physician, not Dr. Peterson, of course. The illness spontaneously cycled every week with 1 good day at an energy level about 6 out of 10 and 6 days of the week with energy level of 2 to 4 out of 10. She had severe cognitive dysfunction and severe post-exertion malaise for 2 to 3 days after just walking 1 block. She had depression and she was crying all the time. She was barely able to walk 1 block, whereas she could swim and ski before her illness. She was a totally normal human being before this. She was napping every day. She was gaining weight. About 3-4 months after the illness started, she returned to Los Angeles to see her primary care doctor because she belongs to what we call an HMO, and then she was evaluated by me. I actually met this patient before several years ago for a spine infection, and after that event, she was a normal person. On physical examination, she had mild throat inflammation, tender anterior neck lymphadenopathy. She had epigastric, which is here, and also right lower quadrant, which is here. These represent the stomach and also the terminal ileum, or the early part of the cecum. And some patients would actually have some tenderness in the left lower quadrant, which is either the small bowel or the sigmoid colon. At the time, EBV, CMV, IgG were positive with a negative IgM, compatible with past infection. Chlamydia pneumonia IgG was 1:8, and normal is just that, and IgM was negative. Antibody titers for Coxsackie viruses B1 through 6 and echovirus 6, 7, 9, 11, and 30 were less than 1:80. HHV6 IgG was elevated at 1:1280. Enterovirus RNA was positive in the first buffy coat, which is the white blood cell layer of the blood. But then I gave her 2 doses of IVIG immediately after this since she was ill. And after that, I could not find the enterovirus RNA in her blood anymore. So from that point on, we actually tried interferons, but she tolerated very poorly. She actually was hospitalized for with severe vomiting. Subsequently, we gave her IVIG every 3 months. She's definitely better, but she's totally distable still. She's probably functioning at about 30% of normal to this day. Well, 3 years after her initial illness, because of her persistent stomach complaints, and endoscopy was done with a biopsy of the stomach. And here we can see, with the enterovirus stain, we can see all these brown spots, which are viral protein in the parietal cells. I do not have a higher magnification. This is on 100x. And this is, I call 2+, which is a fairly extensive amount of enterovirus protein. The next slide, just to talk a little bit about the virology of enteroviruses and the epidemiology, then bring in the protein manifestations of acute infection, how to recognize it, and how does that lead to chronic infection, and provide the evidence that will support that. Enteroviruses are very small viruses. They're RNA viruses, And the best known virus of this group are the polioviruses, which has been nearly totally eradicated from the world except some poor areas. There's Coxsackie A virus, there's 23 strains. Coxsackie B, there's only 6. Echoviruses, there are 26. And there are newer enteroviruses coming up every year as we speak. Now, I think the number's up to about 100 something now. This is an important slide. This actually this is from a textbook chapter. It was a Melnick's book chapter on enteroviruses published in the 1984 edition of Fields Virology. This talks about viruses in water. This is based on the work on polioviruses and also enterovirus 72. Enterovirus 72 has subsequently been changed to hepatitis A. So from this diagram, this is known since the early 70s. Now these viruses are usually replicate in human, and from the fecal material dumped into the sewage. So dump in the sewage can get into different bodies of water. Okay, a river, the lake, can get into the groundwater. Okay, this can be from the river into the lake and get into the ocean, and the viruses can flow as far as 10 kilometers from the sewage dump, and is ingested by the shellfish, and then river, of course, in lakes, people will swim in it, and sometimes go water skiing, jet skiing, and then fall into the water and swallow the water, and you can acquire the water in that way. Groundwater can be mixed with the drinking water. We'll talk about this in a little while. So into the water supply, and when people drink the water, or when you have irrigations using this contaminated water, this can contaminate the crops, and people eat raw vegetables or have exposure to aerosol of these contaminated water, then the human will get infected. Then the cycle will restart from the top. This is well known in the past. The pathogenesis of enterovirus infection, the port of entry, the way this virus enters is usually the GI tract, through the mouth. The incubation period is about 7 to 17 days, but it may be anywhere from 2 to 35 days. So it's a little bit difficult to track down outbreaks because there's such a wide range of incubation period. And acute hemorrhagic conjunctivitis can occur within 12 to 72 hours of inoculation of lice. This is a lot easier to identify when there's an outbreak situation. Aerosol transmission can cause upper respiratory and lower respiratory infections. The initial replication either occurs in the lymphoid tissue of the pharynx, as you can see here, or the gut, especially the terminal ileum. The viremia, which is viruses going to the bloodstream, will lead to growth of the virus in the reticular endothelial cells and then disseminated to the target organs, which we'll talk about in a second. Well, just to impress upon you that water is an important source of this virus. So I quoted one of these very recent studies. This was done in the 11th International Symposium on Respiratory Viral Infections, presented in 2009. The Russians actually studied the risk factors for enterovirus meningitis from 1993 to 2007. I think there were 874 patients, and they identified the risk factors. So number one risk factor is swimming in the river, in the lake. That's 30%. Contact with acutely ill patients with meningitis or respiratory illness is about 12%. Camping, you kind of wonder what they ate or drank in the camp, it was 6%. Drinking raw water, 6%. Drinking raw milk, 2%. And 44% of the patients, the risk factors were unknown. In our geographic area, we tend to see a disproportionate cases of viral meningitis and encephalitis in one hospital. The other hospital is only 3 miles south. In 1 year, we saw 80 patients with viral meningitis in one hospital, only 3 in the other one. This was 10 years ago. This keeps bugging me, but I couldn't figure out what it was. Then more recently, we saw 10 patients that actually came in with brainstem encephalitis, and 3 of them died within a week. And this clearly indicated this geographic location. Actually, it was one city, small city, with a large underground well. And I found out through the internet that actually 30% of the drinking water comes from this well and then get mixed into the water that comes from what we call the California aqueduct. All right? Only in this area we had this brainstem encephalitis. And we actually isolated the enteroviruses from these patients' stool. And when we notified the county and also the state health department, after they found out we found enteroviruses, they were no longer interested, even though 3 patients died already. Probably 5 of these patients were left with neurocognitive dysfunction. They were interested because this wasn't bioterrorism. That's all the emphasis of the public health department is currently. Then, one of the major risk factors in our area, since we're right north of Mexico, people often travel to Mexico, as you saw in that case, Dr. DeMeyer demonstrated. These patients will go there for a day or 2, will ingest shellfish, or just drink some water. And 3 days later, they're admitted with viral meningitis, documented by finding the enterovirus RNA in the spinal fluid. We've seen more than 10 cases of this over the last 5 years. We can just ask them where they went. We know exactly what they have. So traveling to a country with less pure water can certainly result in this infection. What we also found recently was this phenomenon of shingles occurring in clusters. And over the 10 years, we have seen clusters of 3. One dermatologist saw 22 cases in 2 days of shingles. So we knew there was something that was bringing it on. And most of these patients had either a respiratory or diarrheal illness within the previous week before shingles started. So we started investigating this, and what we found was interesting. We documented enterovirus infection in these patients by finding the RNA of the virus in the stool or in the respiratory secretions. And when we did T cells, we are very surprised. Their T8 cells are way down here, way below normal. Here are the T8 cells for our chronic fatigue syndrome, who's been sick for years. Their average is here. These patients' average is way down here. The CD4 cells are also low, but not as low as the CD8. This is a finding Dan Peterson and Dr. Komarov have reported in the Annals of Internal Medicine, I think back in 1992. And some of these patients will come back with recurrent shingles, and by then, these patients' CD8 and CD4 cells are usually normal. A couple of the patients still have very low T cells, but we don't know if they had low T cells to start with, or this is the consequence of the enterovirus infection. So acute enterovirus infection is immunosuppressive, very similar to measles. In the United States, there are 50 million cases of enterovirus infection. This is the data from the CDC, the best estimate for the last 30 years. Although many cases may be asymptomatic, and the patient may just have nothing, just seroconversion or very minor symptoms, most of the patients will have respiratory or gastrointestinal symptoms. This can go anywhere from the nose, sinus, throat, bronchus, the pleura, and cause pneumonia. The GI symptoms typically are vomiting, diarrhea, gastritis. Patient will come in just with repeated vomiting. When we did endoscopies, we can actually see inflammation in the enterum, and we're able to grow virus out of the tissue biopsies. Also, terminal ileum involvement with inflammation, colitis, inflammation of the colon, liver inflammation, pancreatitis, and also acid reflux. We saw several of these cases in children that eventually required corrective surgery, but we could see the virus protein in the stomach. Prolonged fevers, 102, 104 fevers for 2 to 3 weeks are common with this acute enterovirus infection. Leukopenia, low white blood count, and bone marrow failure have all been reported. This is much more severe in the immunocompromised patients, especially the transplant patients. We have seen several of these patients die, either from a lung or from gastrointestinal infection that subsequently spread to the brain. We're able to find the viral RNA in the spinal fluid and the feces. But when physicians heard about that, they weren't impressed. Central nervous system involvement can involve meningitis, encephalitis, or a combination, myelitis, or a combination of the encephalomyelitis, epidemic vertigo, deafness, and also I didn't put here, also involved in the peripheral nerves, peripheral neuropathy. Cardiovascular system, most of you are very well familiar with. It can involve all 3 layers of the heart. So in the inner lining the endocarditis, or the myo or pericardium. Muscle involvement can cause acute myositis, inflammation, and lysis of the muscle cells. Rhabdomyolysis was a large amount of the muscle cells was died at once, especially with echovirus 9. Arthralgias and arthritis, and pleurodenia. Pleurodenia is involvement of the muscles most commonly over the chest wall, the right upper quadrant. But it could involve the flank, the back, and this can be severe, severe pain. And thigh pain are very, very common also with this involvement. Skin rashes are very, very common and sometimes can be rare cases of vasculitis. And mouth lesions like herpes angina, tongue and oral ulcers are quite common. These are clues to acute infections. If patients have symptoms involving these areas, then you have to narrow down which viruses can cause these type of organ involvements. Then you do the proper test to root in or root it out. So diagnosis of chronic enterovirus infection requires a high index of suspicion. If you don't think about it, you're not going to find it. And I'm pretty amazed. Before 10 years ago, I probably did not diagnose a single case of enterovirus infection. I probably missed them all. Now, as I know how to recognize them better, probably a third of the patients I see in the hospital have either acute or some chronic form of enterovirus infection. So the detail of the initial flu-like illness, if present, is very helpful. If someone has a runny nose and sinus congestion and a cough, that will be very unlikely to be either EBV, CMV, or HHV6. And it will be also unlikely to be parvovirus. But if the patient has severe joint pains and in the right time of the season and with ill contact, then parvovirus B19 is much more likely. One needs to scrutinize the initial laboratory studies to exclude other infections. Sometimes the physicians do viral serologies on EBV, CMV, HHV6, and chlamydia pneumonia, and then from that you can tell whether the patient has an acute infection. But that does not exclude the reactivation of these infectious agents. Neutralizing antibodies for enterovirus I'll talk about, and the PCR test for enterovirus RNA in the whole blood, the controversy, okay, and even the peroxidase staining of stomach biopsies, which I already showed you one slide that we'll talk about in detail. And then eventually, one has to assess the clinical situation and look at the laboratory test results. Do they fit? If they don't fit, you move on. That's how I kind of look at this issue. From the animal models and also in vitro data, this is what has been as a hypothetical model of how poliovirus RNA works, play different roles in infected cells. On the right-hand half, as you can see in this cell here, the viral RNA has been rapidly replicated and is translated into protein and cleaved into what we call capsids. And those capsids will wrap around one of these RNAs and this become a whole virion. That's the whole virus. And the virus will disrupt through the membrane, and then you have an intact virus. This will go infect other cells, and the disease will go on until the immune system interrupts. On the left-hand side, this has been well demonstrated in the in vitro and in vivo models, is that somehow after the immune response started, the protein synthesis of the virus is actually interrupted. And so basically what the virus does is keep producing the positive strand of the RNA and also the negative strand RNA. So sometime in this area here, these two can obviously combine into a double-stranded RNA. But you can see here, relatively little bit of this is translated to form a protein. So not very many virions will get released. So this becomes what we call a cryptic infection. It will stay inside the cell, but it can produce all this RNA, and God knows what that can do to our gene function. And these are some of the clinical clues as what chronic enterovirus infection mean. Okay, recurrent tongue ulcerations or aphthous ulcers of the mouth are classic signs of chronic enterovirus infection because we see them in the acute setting. When patients come back from Mexico after eating a lobster, they come in with this horrible viral meningitis. Half the tongue is totally denuded. They never had it before. And then after that, parts of it will not heal. And this is likely chronic enterovirus infection. Here is a patient with herpes angina. Every time he got worse, these little lesions would show up. Initially, there was one time that was much more vesicular looking over the heart pellet. This is one time I took the picture. Don't care? Okay. Okay. Amazing. Okay, I'm just going to go over the data that demonstrated enteroviruses in the tissues of patients. This is also how we'll reconcile the differences between the British and the American investigator. That probably brought a change to this entire paradigm in about 1994, 1995. Well, this is only one patient. This enterovirus RNA was found in the tissues of one CFS ME patient who committed suicide 5 years after she developed this horrible illness. Tissues were removable from the different parts of the brain, heart, skeletal muscles, lung, and spleen, and they were you can see the enterovirus RNA are here, were found in the muscles, heart, hypothalamus, and the brainstem. And the RNAs were sequenced, and we showed about 83% homology to Coxsackie B3. These were done by Dr. McCarty, Gao, Behan, and published in the Annals of Internal Medicine in 1994. One can look at this with the water in the glass analogy, and so the critic will say, well, that's only one patient, so that's not enough. Just give me another 10 patients. Well, I don't think this data is going to come very easily, okay? But the other way to look at this is the virus can get there. It can get there. It's in a patient with this chronic illness. The virus is there. There was no attempt to culture this, but the other study that was really instrumental in helping the diagnosis of enterovirus infection in ME/CFS is done by Clemens, Nairn, Galbraith, published in Journal of Medical Virology in 1995. Well, what they did was that this actually was a blinded control study, and patients fulfilled the Oxford criteria of 91. It was a nested PCR test. The 264 base pair band was generated. They took the serum from these patients. They found the RNA in 41%. The control serum, only 2%. But if you look at the acute infected serum, it's 27%. This is about what I see also in adults. In patients with acute enterovirus infection, it's actually very hard to find it in the serum. It's much easier to find it in the stool or respiratory secretions. The Buffy coat culture RNA test was 27% positive. So roughly 35% on the average they could find. But the controversy in 1994 was that the American investigators, Dr. Stephen Strauss, could not reproduce these findings. So this is an important thing for me to read it to you, because this is really what changed the paradigm at that time. Dr. Strauss wrote, I quote, "In Britain, the preeminence of a neuromuscular hypothesis of CFS sustained a preoccupation with enterovirus as an etiologic factor for 2 decades. The weight of evidence stands largely against us now." I quote, "This report on the Joint Working Group of the Royal Colleges of Physicians, Psychiatrists, and General Practitioners on CFS does note one blinded study, which I just showed you, in which EV sequence was detected more often in the sera from patients than from healthy controls, still awaits repetition. Our own blinded study using PCR found no EV RNA in the sera or other specimens from patient or control subjects." Dr. Rothbard is in Denver and is a world expert on enteroviruses, and he did the study. The study was not published. Exactly how they handled the blood, we do not know. This is his technique. It's basically a RT-PCR EIA type of technique, and Dr. Rothbard actually patented and gave the technology to a company. We actually bought the kits from this company, but this company actually improved upon this technique by adding one more primer. There were 2 primers in those studies, and there are 3 primers. This is one of the studies we did. The clear color wells are the negative ones, and the yellow color wells are the positive. And here's a negative control, here are positive controls of 80 to 800 copies. What we did, Andrew, my son, and I actually did all this. Andrew did all the laboratory work. We actually tested the patients. Initially, we had 131 patients, and 50 of them were positive. This is 38%. These are the most symptomatic CFS patients. They tested positive twice or more. Only 4%, or 2 out of 25 patients, of the controls were positive. Then we went on to test multiple samples from each patient. So from February 2000 to August 2005, more than 2,500 blood samples were drawn from more than 510 patients, and about 35% of them are positive. If you look at the sickest patients, the bedridden patients, 70% of them were repeatedly positive. But patients who had better energy level, 4 to 5 out of 10, only 12% of them positive. On this side, the right-hand side, you can see as we done the RNA test every 3 months, some tests are positive, some tests are negative. They're rarely ever positive every single time. So this tells us it's very difficult to find this. And we asked the question, could it be because of assay sensitivity? But at that time, when we did this using a qualitative control, we estimated we could detect somewhere between 80 to 800 copies of the RNA per milliliter of blood. We can prove this point now. This is what we did using the PAX gene tube, which can preserve the RNA. These viruses exist in RNA form, not actually intact virion. The RNA are not stable, so if you don't preserve it, the evidence will be gone in several hours. So 27% of the PAX gene tubes were positive, and 25% of the acid citrate dextrose A tubes, this is just a regular yellow top, were positive. But these samples we handled within 2 hours of the drawing. The PAX gene tube, we could handle it, we can deal with it in a day or two. 29% of the PAX gene samples were positive for eVRNA when we did 226 patients, and some were confirmed by sequencing. We took some of these positive samples and did a quantitative RT-PCR. And it's very interesting, if you look here, there's only very few people, in fact, one that had 1,500 copies per milliliter. The rest of them are really low. The median is only about 53 copies, and the mean is about 200 with a standard deviation about 300. So this explains, I believe, the discrepancy between the laboratories in the previous reports. This is a very difficult test to do, unlike HIV. HIV is easy to find 50,000 to 100,000 copies of viruses in each milliliter of blood. In the AIDS patients, you can find millions easily. So at this level, I think it's very prone to discrepancies. The next test, so that was test on the blood viral RNA. This test is hard to do, and it's not standardized, and different laboratories can be different in terms of sensitivity. We do not find this very useful, but 30% of the patient could be diagnosed this way. The next test is the neutralizing antibodies. This can only be done by this laboratory, ARUP, which is Associate Regional University Pathologist Laboratory in Salt Lake City, Utah. This is how we actually, by serendipity, found out that these patients have elevated antibodies. The typical antibody the laboratory will do is called the complement fixation test, which is neither sensitive nor specific. That means if you get a positive test, it's worthless. And then if you get a negative test, it's worthless. Well, that's wonderful. But finally, by serendipity, we found out some patients have the sky-high antibodies we've never seen before. So what we did is on the right-hand half, we took the blood of 200 CFS patients. And then we also took 100 of the controls. These are either spouses, relatives, or sisters, brothers, and patients who came to the clinic the same day for other type of infections. And we compared them. You can tell the difference is black and white. Here, the average is much lower. So if any patient has over 160, it's considered positive, except for Kawasaki B4, which runs a little bit higher. So if it's 320 or above, we consider positive. We have been using this since 1998. It's helpful, but it does have its limitations, which I'll compare in a second. The next thing we did, because we presented all this data at the Infectious Disease Society meeting, and out of 12,000 people attended the meeting, only 10 people ever came to look at the poster. So we realized this is not enough. We have to find out. We have to actually see what the virus is. But trying to get a tissue from a brain, a heart, and muscle is a major to-do. It's just not possible. So what we decided to do is to look for the initial site of replication, which is either the pharynx or the stomach. We did look at a few tissues from the tongue and the mouth, and also terminal ileum. We did find a little viral protein and a large amount of viral RNA. But these specimens are hard to come by. But almost by the time we are interested in doing this study, more than 200 patients have had endoscopies and biopsies. So this is a typical look on endoscopy. This is the enteron. This is the little opening that goes into the duodenum. You can see some red areas here, kind of subtle. If you don't really look hard or if the patient is on proton pump inhibitors or some sort of acid suppressants, you won't see this. Well, you see this here. It's very impressive. But a patient with all this redness may not have symptoms. It's pretty amazing. So we took biopsies of these areas and stained it with an enterovirus-specific monoclonal antibodies. All those brown spots are enterovirus proteins. This is a control with anti-CMV antibodies. Okay, this is a 2+. This is a 1+. You can see much less staining. And here's the 400x magnification. You can see the staining. You see the parietal cells. The cells that produce intrinsic factor and also acid. This is another 4 examples. Here's 2+. This is almost 2+, 1+, and this patient did not stain. It's very clean. It's very blue. And here's the patient that we were trying to establish that the initial gastrointestinal infection was still there a few years later. So this was the very first biopsy in the first week of gastrointestinal illness, which the patient was hospitalized. And the patient had a lot of the viral protein in the interim. 4 years later, when the patient already has CFS for 3+ years and continued gastrointestinal complaints, we can see the protein is still there. So there is viral persistence. So overall, when we published this paper in the Journal of Clinical Pathology, we had 165 specimens, 82 are positive from the CFS-ME patients, and also on only 34, and 7 out of 34, 20% of the controls staying positive. So eventually, we added more controls and more CFS-ME patients. To date, we have done 351 samples, and 82% are positive, and 11 out of 56, or 20% of the controls were positive. If we use 2+ staining, the extensive staining as a positive test, then 55% of the patient samples were positive, and 5% of the controls were positive. That gave us a specificity of 95%. That means when it stains 2+ like that, there's only 5% chance. That's a false positive. Okay. This was the supporting evidence that the viral protein meant something. What we did was that we took stomach specimens, we did the stains, BP1 staining. A separate piece was analyzed for the enterovirus RNA. These were already preserved in a preservative called RNA later. And then we also took the specimen, we ground it up, and tried to grow in the cells. As you can see here, a number of the patients grew the virus about 6 weeks. It took a long time. Dr. Chapman told us to be very patient. So very, very patient. But we got very itchy by the 4 weeks. Some of them are positive. By 6 weeks, they're more positive. When we ground up the cells of these patients and we pass it into another culture, you can see some of these patients, the biopsies were still positive. And the stains were positive here. They don't always correspond. And out of these, the 2 crosses here, this actually with the RNA sample, we sent it to Dr. Chapman, Dr. Stephen Tracy's laboratory. They independently found viral RNA that corresponded to the cultures. So we can actually see these viral proteins in different areas. One patient had severe sore throat for more than 15+ years, and she was sick and tired of it, so she underwent 5 biopsies of her throat. We could see the viral protein probably in the macrophage. We haven't done double staining and to show this is dendritic cell or macrophages. This is in the posterior lingual tonsil. But a comparison, which is just right posterior to her, the posterior tongue biopsy, showed no staining here. 5 years later, she actually developed thyroid cancer, probably on the basis of chronic Hashimoto thyroiditis. We can see the viral proteins in the follicles of the thyroid, but a control stain with HHV6 did not show any staining. We can see this in sinus tissues in patients who have recurrent sinusitis. Remember the respiratory infections, and patients just keep getting sinus congestions. About 50% of the samples were positive here, and the CMV antibody was negative. So we compared the neutralizing antibody, enterovirus RNA of the blood, and BP1 staining of the stomach biopsy. I don't think I need to bore you with all these details here, but basically the enterovirus BP1 staining of the stomach biopsy is more sensitive than either the neutralizing antibody test or the qualitative or quantitative eVRNA assay for the diagnosis of chronic enterovirus infection. Elevated enterovirus antibody, which we can only do for 11 of the enteroviruses, can confirm the serotype or serotypes of the enterovirus involved. So the 2 tests are complementary. So what do you do about this awful illness if one believes in what I'm saying? Well, symptom-based treatment, we already talked about that, and the immune modulation, I think a number of speakers have touched upon. I will talk also about IVIG and present some of the data that's been published in the past. Ampligen, I won't talk about. Dr. Peterson nicely described the effect of ampligen on some patients. Interferon in the Chinese immune booster or enhancers, specific antivirals, including the anti-capsid drug, pleconazole, and future antiviral drugs. Well, one needs to first understand what happens. This has been talked about for at least 15, 20 years. Many laboratories have shown that there's immune dysfunction in CFS ME patients. I don't need to stress on this, but just to illustrate that the immune system, especially the T helper cells, work in a balance, like a seesaw. And the way you're supposed to fight a virus is you're supposed to shift the seesaw this way with Th1 dominant response. This will kill off the virus. And then after a few days, and the Th2 side will say, hey, time to stop. This is a check and balance system. If you continue this ongoing attack, you're going to create an autoimmune disease or some sort of horrible thing. So then the seesaw will go back to the horizontal line. But unfortunately, I think a lot to do with viruses or pre-existing type of illnesses, such as atopic diseases, which tend to shift the immune system to the Th2 side, steroid treatments, second half of the period. So the 2 weeks before the menstrual period, there's good data that suggests you're in the Th2 side because you don't want to have a robust immune response when you get pregnant and actually kill off the embryo. And vigorous exercise, marathon runners are known to have a Th2 dominant response, and prior infection when it's closely spaced. So if this one dominates, these type of cytokines will come out. The Th2 cytokines are favoring this Th2 dominance. It's IL-10, IL-4, IL-5. On this side, gamma interferon, interleukin-2, IL-12. On this side, you eradicate the infections I stated. On this side, this will basically promote what we call persistent infection. And recently, Th17, Dr. DeMeyer has mentioned this before, but a very nice article published in the Journal of Experimental Medicine 2 months ago actually clearly shows that Th17 cells predisposed to viral persistence and also possibly the persistent hyperimmune response, or some probably call it autoimmune response. If you are interested, you should read this paper. Is there anything we can do about this immune balance? Well, the IVIG, Dr. Peterson have talked about quite a bit. Well, the data that's been shown in a prospective randomized studies, there were 2 back-to-back studies published in the Annals of American Journal of Medicine in 1990. The first study was from Australia that showed a benefit using 2 grams per kilogram per month, and 43% of the CFS ME patients responded, and 11% of the placebo-controlled treated patient responded. The second study was done in Minnesota, and of course, our IVIG preparation probably a little bit different because you get it from donors who actually have experienced these type of virus infections. So it depends on the experience of the prior experience with these infections. The antibody levels to certain specific antiviruses can be different. In this particular study, they used 1 gram per kilogram every 30 days for 6 months, and there was no difference between the treatment group and the placebo control group. Well, obviously the difference here was the dose, there's other reasons too, but the difference, obvious reasons, is the dose. So the Australian group subsequently did a varying dose study, 0.5, 1, 2 gram per kilogram versus placebo every month for 3 months. There were 99 patients stratified into 4 groups here, so there are not that many patients to start with. In this study, there was no significant difference, but there was an adverse reaction seen in 70 to 80% of the IVIG recipients. Okay, so from this point on, the insurance company will not cover IVIG for the treatment of ME/CFS. That's what they quoted. Didn't work, right? Okay. Well, using IVIG, I believe, is an art. It's very different than using a drug called like calcium channel blocker or beta blocker for a very specific reason. IVIG has multiple functions on the immune response. So the fact that it didn't work here does not preclude the use of this IVIG in certain patients. Jonathan Kerr, here's the adolescent data. Dr. Rowe in Australia actually used 1 gram per kilogram per month for 3 months. And there were 71 adolescent patients. there was a significant improvement in IVIG-treated patients compared to placebo. I find the same, which I'll mention. The IVIG was effective against parvovirus B19 infection. This was published in CID 2003. I have similar experience. But the elegant test that Dr. Kerr had done, he was able to show that there was improvement of cytokine dysregulation and clearance of the parvovirus B19 viremia. My experience of treating ME/CFS patients, I used 0.4 gram per kilogram, 1 month apart times 2 doses, then every 2 to 3 months if it's effective. If it's not effective, I don't use it anymore. But this doesn't mean someone won't respond to Q monthly therapy 6 months to 12 months from there. It's just the insurance company won't cover it. So some patients actually do respond to that therapy when they can get it. Well, I see about a third of the patients improved, and 70% of the adolescent patients responded, but that's only 10 patients. 3 out of the 7 adolescents relapsed after vigorous exercise. And they did not respond to repeat IVIG treatments. So this is the difference on 2 patients. One is adult. So I gave the patient IVIG, the echovirus 6 titer, which was over 640, actually nicely dropped for the adult patient. Then it increased up. 8 months later, the patient relapsed. This is a pediatric patient that started with 640 here, then actually dropped like this. Why is it different? I don't know. That would be something to investigate. The next treatment option is interferon and ribavirin. Interferon and ribavirin have excellent activity against Coxsackie B3 in the cultures. I'll just show you this panel on the left upper side here. This is my son's data. On the y-axis is the titer of the Coxsackie B3 antibodies. So he started off at 640. He's remained elevated. When he first received ribavirin, the titer dropped down to 80. Stayed at 80, and he stopped his treatment about 4 months. And then the titer increased again, to 320. Enterovirus RNA showed up again, showed up the first time in 2000. They were 2 weeks apart. And we treated with interferon and ribavirin. The titer came down here nicely. He did well. Then we went to Hawaii and climbed the Diamond Head volcano. He relapsed afterwards here. Viral RNA showed up. The titer went up. Basically, the patients follow the same pattern. Interesting enough, my son also has Coxsackie B4. For Coxsackie B4, the antibody titer did not change at all, which is what I usually see using ribavirin and interferon. It's ineffective against Coxsackie B4. Then we thought we had to use a stronger combination, so we used the alpha and gamma interferon. Here's a patient that started off at an energy level average. This is a total energy level for 2 weeks. So the maximum is 140. She started at 30. Okay, and we gave the 2 interferons. Her level even dropped down. This was a difficult treatment for her to tolerate. But the one thing we noticed that her heart function actually was reduced to 40%. At this point, we actually did an echocardiogram and actually improved to 65%. So we knew this helped her. In a month or 2, her energy level shot up like this. She went back to full-time work for about 6 months. Then she went to Hawaii and had vigorous exercise, and then she relapsed. When she relapsed, the RNA showed up again, just like what she had before, but remained negative here. She rested about half the time. She only worked half time, and then she went back up. Over this point, she picked up 20 more hours of work. So she was working 60 hours a week and staying up from 7 till 11 at night, taking care of 3 kids, happy as a bird. Then eventually she fluctuated and had to be retreated here again. This is a Kaplan-Meier survival plot, basically just see how long the interferon response lasted. To make a long story short, there were 62 patients treated. About 30%, about 47% of the patients responded to the combination therapy. A number of the patients actually responded more than 2 years. And these are the patients that have severe body aches, okay, that really responded. Within 2 weeks, the body ache was completely gone. This is just a quick slide on cytokine gene expression study that we picked. The first 4 patients, one of them was a psychiatrist, was able to work about 40 hours a week, but she had to drink 5 cups of coffee every day. The other 3 are bedridden. You can see this one stuck out like a sore thumb, and this is interleukin-12 P40 gene expression. So, and the IL-2 level gene was up, and the IL-10 was low. So from this point on, we were looking at the various cytokines. There are 12 of them we were looking at between the patient who can work and who cannot work. As you can see here, there's really no major difference except for this red open bar here and the shaded bar here. This is the one that were not able to work. These are the patients that actually could work. This is actually a interleukin 12 over interleukin 10 ratio. This is another version of that. As you can see, normal is about 1. These are the patients that cannot work. These are the patients that could work. So it's statistically significant that more of these patients actually have a more favorable IL-12 P35 plus P40 over IL-4, IL-10 ratio. This leads us to the last thing I think some people want to hear about. I may take more than a minute here. What we did was that we were looking for immune boosters that could shift this immune balance to the right direction. And one such herb is called oximetry, and this has been used in China as an antiviral drug for hepatitis B. In fact, 50% of the patients with chronic hepatitis B will respond, will actually cure their infection after taking this herb for a whole year. Well, and the reason they found this worked is not because it clears virus in the transgenic mice model, but actually shifts the immune response to a Th1. So we found this very attractive. So what we did is we had the patient import the oximetry from China, and the initial 100 patients that we treated, 52% of them responded. They either were better or much better. We did not do the fancy objective studies that Dr. Peterson mentioned. The next 114 patients we observed. We did not treat them. Only 7 out of 114, the 6% of the patients, of these patients improved. So the difference was huge. So then we gave this to the next 104 patients. Again, 52% of the patients responded. Age, sex, and duration of illness did not seem to correlate with the response, but I think the standard deviation was so large we couldn't miss some of the patients with a shorter illness and more functional level probably responded better, but we can't say that based on what we had. 53% of the patients with elevated enterovirus antibody for the 11 enteroviruses responded to therapy, whereas 50 of the patients with the negative antibodies improved. 52% of the patients with positive enterovirus protein in the stomach biopsy responded, whereas 56% of the patients with negative biopsy responded. The relapse of symptoms was quite common. It was seen in 2 out of 3 patients post-discontinuation of the oximetry after 3 months of therapy. So from that point on, we continued it to 6 months, and now we actually is up to about two and a half years. The patients actually did fairly well if they can tolerate it in the first 3 months. 13 out of the 15 patients who relapsed respond to restarted treatment. We also did the gene expression studies just right before they started oximetry and also during oximetry treatment. These 7 that slanted up all responded. You can see a shift into the Th1 cytokine. The bottom 10 did not respond, and they did not change at all. In fact, some of them went down. So we have asked for funding to do a prospective randomized double-blinded study from one of the CFS organizations. We were denied the funding. It's sad because we like to show this to be an effective treatment. So we basically gave it to another 100 patients, and the efficacy is about 52%. It hasn't changed. There are side effects associated with this. Okay, the most common symptoms are whatever the symptoms the patient already had. There's an increase in these symptoms. So myalgias, headaches, abdominal pain, nausea, diarrhea, fatigue, palpitations, sinus congestions, and one patient actually developed high fever at 2.5 months of treatments, 104, 105 fevers for about 5 days. And guess what happened to this gentleman? He's been in remission for 2.5 years. Before that, he could only be out for 1 hour a day. And now he's back to work traveling the world. Increasing dizziness, insomnia can also be seen, weight gain, edema, which the patient already had, joint pains. 2 of the patients developed markers of rheumatoid arthritis. One of them had to stop and see a rheumatologist. The other one, the symptom resolved after discontinuing of the treatment. 2 patients had elevated blood pressure that prompted discontinuation of the treatment. Rashes was seen in 1, dry eyes and dry mouth, and herpes outbreak when the drug was stopped. Fluconazole, I'm not going to mention because I don't think it will work. This is basically showing you the possible drug targets inside of infected cells. Yeah. And There are a lot of possibilities. If one believes in this, this can happen, just like AIDS. There's a disease we didn't think we can possibly treat. Now have more than 20 drugs that we can use. And the last one I need to acknowledge is all the investigators who have worked on enteroviruses before I have. Without their work, there's no possible way I would even have thought about enteroviruses. My wife, who's been constant support throughout this effort, John Chia for his generous financial support, Yulia Science for part of the support for the stomach biopsy, my collaborator Nora Chapman and Stephen Tracy at University of Nebraska, and all the patients who participated. Thank you.